My name is Scott Stretch. I'm the Chief Administrative Officer of the Cardiovascular Institute here at Eisenhower. I have the honor of leading over 325 healthcare heroes that help fix over 1,000 broken hearts a day. I want to thank the nearly 600 people that have signed up for this conference today. You're going to hear some really amazing speakers talking about some of the most advanced treatments that we offer here at Eisenhower to treat cardiovascular disease. Cardiovascular disease is the #1 killer in the world. In the Coachella Valley, we have a significant prevalence of cardiovascular disease. Atrial fibrillation is going to grow by 98% in the valley over the next 5 years, heart failure by over 45%. So you're going to hear a lot about the things that we can do to help combat that today. I want to introduce Dr. Philip Patel. He is my partner in leading the Cardiovascular Institute. He trained at Mayo and has been practicing for over 22 years here in the Coachella Valley. So with that, I'll turn it over to Dr. Patel.
Thank you, Scott. Well, good morning. Great to see you all here today. Right? Thank you for coming. And I know we have also a tremendous amount of people who are on Zoom. How many? I think they said over 300 people are also have joined by Zoom, in addition to who's here today. So welcome to all of you who are on Zoom as well. And great to have you here. Welcome to our 4th annual Cardiovascular Symposium. I'm Dr. Phil Patel. I am the president of Desert Cardiology and also the medical director of non-invasive cardiology at Eisenhower. I have the privilege of doing the first lectures on heart failure. I'll talk about the definition and then management of heart failure, and I'll save time in between the talk for some questions and at the end of the talk for some questions. Okay, so first of all, I have no financial disclosures. Broke, basically. And let's talk about the prevalence of heart failure in the United States. If you look at this is the the latest article published in the Journal of Heart Failure just last month, looking at what we call heart failure stats, 2024. Approximately 6.7 million Americans have heart failure, and it will be increasing to, and these are the patients over the age of 20, it will be increasing over the next few years to hit 8.7 million by 2030 and about 11 million by 2050. So pretty significant prevalence of heart failure in the United States. Heart failure costs the nation close to $30 to $31 billion annually, and this includes costs of healthcare services, costs of medications, time off of work, all adding together a very incredible cost to the nation for heart failure management. We also know that it's the major cause of death in the United States. In 2022, heart failure was mentioned in over almost 500,000 death certificates. Heart failure is the #1 cause of hospitalization in Medicare patients. Medicare patients. It's the #1 cause of hospitalization, more than heart attack, more than stroke, more than influenza. And heart failure mortality rates have continued to increase. There was a very big bump during the COVID period between 2020 and 2021. Black individuals, American Indian individuals, and Alaska Native individuals continue to have the highest age-adjusted heart failure mortality rates. This is CDC data looking at the death rates in the United States of heart failure between 2014 and 2016. Adults over the age of 35 and separating it by county. Every single county in the United States is affected by heart failure death not unexpectedly, and more so in the areas where they have very poor healthcare, such as in the Deep South. Here's Mississippi, one of the states with the worst healthcare records, having the highest death rate for heart failure. Again, not unexpected. Worldwide, heart failure prevalence is still very high. This was according to the Global Burden of Disease Study. The global burden of heart failure is affecting close to 60 million people worldwide, with a prevalence rate of over 700 per 100,000 individuals, a very significantly high morbidity and mortality rates. Now, how do we define heart failure? Why do we have to define heart failure? We have to define heart failure because previous to this document being published in 2021, heart failure was called many, many things. Some people said congestive heart failure. Some people said systolic heart failure. Some people said forward heart failure. Some people said backward heart failure. So there was no consistency amongst doctors. There was no consistency amongst societies. So American societies, European societies, there was no consistency amongst researchers. There was lots of discrepancy. And because of that, the treatment wasn't really uniform. So that's why the first step is get a consensus definition. Get a consensus definition. And the three major societies in the world, American Heart Association, Heart Failure Society of America, I should say, the European Heart Failure Society, and Asia's Heart Failure Society got together, created this working document. Created this working document, and it was published in 2021. And finally, we have a universal definition and classification of heart failure that we can all speak the same language. It is actually a very simple but conceptually very comprehensive document. It has near universal applicability, very good prognostic and therapeutic validity, and absolutely acceptable sensitivity and specificity. Okay? How do we define it? What does it mean? First of all, it says heart failure is a clinical syndrome that has either ongoing symptoms or you had symptoms in the past. Okay, that's step number one. So you have symptoms of heart failure or you had it in the past, and it's caused by some type of structural or functional abnormality of the heart. Okay, that's the first part. Then you have to have it corroborated by one of the following, either an elevated natriuretic peptide level, and I'll talk about that a bit more, and or some type of objective evidence of congestion. Okay, so those are the basic ways that we define heart failure. Okay, let's explore that a little bit more. What are, when we say symptoms and signs of heart failure? This is myriad signs. We know about these. Shortness of breath at rest, shortness of breath with doing anything, climbing up a flight of stairs and getting short of breath, waking up in the night short of breath, swelling in the ankles. These are so many of the most of the heart failure symptoms that we very well know about. There are some that are not too well talked about. Depression. Depression is a symptom of heart failure. And there are so many others that are there, but you have to have some type of sign or symptom of heart failure, either now or you had it, okay? Then, again, here's a kind of a pictorial of it. The person sitting forward can't lie down flat because of the shortness of breath. The legs are swollen, the lungs are full of fluid. This is classic heart failure. And it is caused by some type of structural or functional cardiac abnormality. What do I mean by that? Something wrong with the structure of your heart, okay? Something wrong with the structure of your heart. That could be that the heart pumping function is weak. That could be that one of the heart chambers is enlarged. That could be that maybe the walls of the heart are thickened, left ventricular hypertrophy. Maybe you have a bad leaky heart valve. Maybe you have coronary disease and have a stent put in there. Something wrong with the structure of your heart gives you what we call structural heart disease, okay? So if you have structural heart disease, that is one of the key features for developing heart failure, okay? Then we can talk about functional abnormalities, such as increased pressure inside the heart is a functional abnormality. That's derived by one of these echo variables. E over E prime is an echo variable to tell us how much pressure is inside the heart. Or you can also have elevated brain natriuretic peptide. Okay, so something wrong with the structure of the heart or something wrong with the function of the heart, that's one of the components of the definition of heart failure. When we talk about it, it has to be corroborated with one of the following: elevated natriuretic peptide level. What is that? Natriuretic peptide level is a small protein that's secreted in the upper chambers of the heart anytime the heart wall is stretched. Okay, so if the wall is stretched, if you have volume overload, then you'll see an elevation of the natriuretic peptide level. We have two forms that we check. One is called BNP, the other is NT-proBNP, and they have values which are normal for outpatient and inpatient. And this can happen transiently. If you were to go out, say, and eat a very salty meal, and I check your blood the next day, your BNP level could probably be high, okay? So it can fluctuate. Now, if it's persistently high all the time, then it's pathologic. But the one-time high and come back down, that's not, okay? Because that can be reflective of just having a excessive sodium load for any given thing that you did, okay? So we see this a lot. Patients will come in, they'll see me, they'll have their labs. What's this? Why is this high? What did you eat last night? Chinese food. There you go. So it happens. It can happen. But if it's persistently high, then it's pathological. And these are the ranges for normal, for inpatient, and for outpatient. So you have to have one of the following: elevated BNP levels, or some type of objective evidence of congestion, okay? And we can find that in a number of ways. You can get a chest X-ray, we can do an echocardiogram, nuclear studies, heart catheterizations, cardiac MRI. There are many ways to find out if you have objective evidence of congestion. So once we have that, then that's also in our definition. So once we have defined it, now we want to classify it, okay? Now I want to classify it because remember, this is the universal definition and classification of heart failure. I want to classify it, okay? Prior to this article, prior to this consensus document, we only had two classes of heart failure. And in the layman's terms, it would be forward heart failure or backward heart failure, or systolic heart failure or heart failure with a reduced ejection fraction. That's all we had. So we had heart failure with a reduced ejection fraction. That's an ejection fraction less than 40%. 60% is normal, okay? So this is all we had. We had heart failure with a reduced ejection fraction or heart failure with a preserved ejection fraction. These are people with an EF greater than 50%, okay? With our new document, we now have added two new classes. We have now heart failure with mildly reduced. These are people between 41 to 49%. Okay, mildly reduced. And the mnemonic for these people, this one was for the reduced, we call it HFrEF. And for the ones where preserved, we call it HFpEF. So the heart failure with mildly reduced, I think they're calling it HF-Mr. EF or HF-MR-EF. And then we have heart failure with improved ejection fraction. Now, these were people who previously had a very low pump. They previously were less than 40%. Then we gave them medication, therapy, what have you, and they got better. They improved. They got better. They improved to greater than 40%. So we call them now heart failure with improved ejection fraction. And you can say HF-MPF. I don't know how they say that. So these are the two new categories we have. We don't say that it's heart failure with a recovered ejection fraction, okay? We don't use that term because when we used to do that, we used to say, oh, we fixed the patient. We've cured the patient. We have recovered their ejection fraction. And in having that mindset, often the patients would stop the medicine. The doctors would stop the medicine. They thought we cured you. But unfortunately, it's because it implied that the pathophysiology was inactive. But when we did that and we stopped the medication, the heart failure symptoms came back. So we never use this term. We never use this term. We want to say that we don't want to say we have a recovered ejection fraction. We just put you in remission. That's what we did. So you had heart failure and we put you in remission. It means the pathophysiology is still active. It means you must stay on the medicine, okay? Because if you take the medicine away, it comes right back, okay? Also, we don't want to say chronic or stable heart failure. There's really no such thing as stable heart failure. We say persistent heart failure, okay? Persistent heart failure. So these are all from the new classification scheme. The next is, what are the stages of heart failure? Okay, prior to this document, we used to have stages from our society guidelines, stage A, B, C, and D, and they're a continuum. You start at A and you move over to D if things go worse. So let me describe that to you. Stage A, and these are people who are at risk of heart failure. And you can think about this is a huge amount of the population. These are people who are just at risk. They have absolutely no signs or symptoms, absolutely no structural abnormality whatsoever. Maybe your father had heart failure. There you go, you're stage A, right there. Maybe you had exposure to some type of chemotherapy that's potentially cardiotoxic, or stage A. Maybe you have high blood pressure. Maybe you have diabetes, you're stage A. These are a vast, vast majority of the population. Just walking around at risk, they're stage A. Okay, it means at risk only. All right. Now, as the continuum progresses, we move to stage B. Stage B people are pre-heart failure. Okay, you're not heart failure, you're pre-heart failure. All right. I often get this question almost every day because, you know, patients like to read their my chart, unfortunately, and then they come in and they say, "What's this? Why do I have heart failure?" I say, "You don't. You have stage B, which is pre-heart failure." Okay, like you've heard of pre-diabetes, similar concept. Okay, it means that you don't have any signs or symptoms whatsoever, but you have some type of structural or functional abnormality of your heart. Maybe you had a stent. Maybe you have a leaky heart valve, had a valve replaced. Maybe you have an increased heart chamber. Something wrong with the structure of your heart. Without any symptoms, you're a stage B. Maybe you just have elevated BNP levels. Okay. Maybe you eat Chinese food every day. So you're stage B. All right. Stage B. All right. Now, as we progress in the continuum, now you got symptoms. Any of those symptoms that I showed you. Now you have symptoms. In addition to having a structural functional abnormality, you now have symptoms. You're now a stage C, real heart failure. Okay, stage C. This is real heart failure. Now, these people we treat as aggressively as we can. And hopefully, we can put this person in remission. Okay. However, sometimes we can't, and then they're left with persistent heart failure. Follow me? Okay. Now, as the continuum progresses, if unfortunately it does, you go to stage D. Stage D are our advanced heart failure patients. These are the patients who require special therapies, possibly mechanical therapies, possibly transplant, possibly hospice, all sorts of things. These are the stage D or advanced therapy patients. Okay. So those are the stages. And then if you put this all together, we now have, and it's kind of busy, but this is the definition. These are the stages. These are the classifications. Again, defining heart failure, it's a clinical syndrome that has symptoms or had symptoms, okay, corroborated by one of the following: elevated BNP level or increased evidence, some objective evidence of congestion. You have the stage, you're A, B, C, or D, and we talked about what those were. And then the classifications we talked about: HEF-PEF, HEF Mr. EF, HEF-REF, Mr. EF, HEF-HEF, or HEF with improved ejection fraction. Okay, so this is now again how we're defining heart failure. All right. Okay, now we've done the definition. Let's talk about the first category would be heart failure with a reduced ejection fraction. These had been our mainstay of therapy. It's changing now, and I'll go through that a bit more. But heart failure with a reduced ejection fraction is anyone with an ejection fraction less than 40% with symptoms. Okay. When we talk about heart failure with a reduced ejection fraction, we have to define what's systolic performance. This is, so your heart pumps, it ejects blood, it pumps, it sends blood out of the body. So that's cardiac output. It's the ability of the left ventricle to empty, and we measure that with an ejection fraction, how much blood is emptied out of the heart every time it squeezes. It's not 100%. Normal is 60, because you always leave some blood left in there. Okay, any decrease, anything that affects that systolic performance will lead to systolic dysfunction or HEF-REF. Okay, and it's always caused by something wrong with the muscle of the heart, some type of cardiomyopathy, I put down here the top 5. Ischemic cardiomyopathy, or we saw from the coronaries, something wrong with the plumbing. You're not getting enough blood to the muscle of the heart. That's ischemic cardiomyopathy. When we talk about valvular cardiomyopathy, something wrong with the valves. Perhaps the valve is leaking severely or narrowed severely, so you're having either more pressure in the heart, in the upper chambers, which pushes back and creates heart failure. Alcoholic or drug induced cardiomyopathy. When we talk about drugs, we're talking about the amphetamines, methamphetamine, cocaine, very common causes of cardiomyopathy. Alcohol, heavy alcohol use also causes cardiomyopathy. There are arrhythmogenic cardiomyopathies from bad rhythms that can create cardiomyopathies. And then there's a whole slew of others called primary cardiomyopathies, and that can be a subject of an entire lecture. We can break it down to genetic ones, which are familial. We can break it down to mixed and acquired. Acquired are like infection, like a myocarditis. Stress cardiomyopathy, we also call that broken heart syndrome from catecholamine stress. That's an acquired cardiomyopathy. Peripartum cardiomyopathy. There's another one called tachycardia-induced cardiomyopathy. If you're having atrial fibrillation, going really, really fast all the time, that can create a cardiomyopathy. And then there's these others mixed, and then the genetics. There's a whole lot of genetic ones. Very common would be the hypertrophic cardiomyopathy. You may have heard of those. And then there's so many other genetic causes of a primary cardiomyopathy. Again, that's probably a lecture in itself. But either way, we have to now treat these patients, and how we treat them is we do what's called guideline-directed medical therapy, GDMT, guideline-directed medical therapy. That means we give you a medicine and we upwardly titrate it to the maximum that you can tolerate, okay? Now, the problem is that kind of a double-edged sword. If you have HFrEF, your heart doesn't pump well. So the engine doesn't generate enough steam. So you're already at a low blood pressure. Then I give you all these medicines, which bring down your blood pressure. So it's a balancing, trying to get you to what you can tolerate, how much you can tolerate without passing out or dropping out, things like that. Now, this is our latest update for management of chronic systematic heart failure, and we always want to treat what's guideline-based. These are based on what's called the class of recommendation, and all based on the level of evidence. Green is good. Green is class 1, okay? Yellow are class 2A, and then orange are class 2B. Red is bad, class 3. There's no class 3 indications on this chart. So if we're looking at our class 1 indications for treatment, we have our 4 standard pillars of therapy that we use. The first are these ACE inhibitors, ARB drugs, or angiotensin receptor drugs, or ARNI drugs. These are afterload reducing agents. Afterload reducing agents. That's our first line therapy for heart failure, okay? So ACE inhibitors, such as lisinopril, captopril, ramipril, ARB drugs such as valsartan, losartan, anything that ends in a tan, those are those ARB drugs. And then the newest is our ARNI drugs. Of that is Entresto. There's only one, Entresto. Entresto has been shown to be one of our best drugs for heart failure therapy if you can tolerate it and if you can afford it. It's exceedingly expensive. So, but it really is one of our best drugs. Then that's our first pillar of therapy. Our second pillar of therapy are beta blockers. Beta blockers slow down the heart rate. If you slow down the heart rate in heart failure, you allow the heart time to fill. Otherwise, the heart's going really fast. It doesn't get it to fill. So you allow the heart to fill. Give it a break. Give it a break. Let it fill. You improve contractility. It improves cardiac function. Of those drugs, there's only 3 beta blockers that have been shown to be of help in heart failure. One is carvedilol or Coreg. The other is bisoprolol. And then the third would be metoprolol succinate. Our third therapeutic pillar are mineralocorticoid receptor antagonists, and these are diuretics. These are potassium-sparing diuretics. There's only 2 of them. One is spironolactone, and the other is eplerenone. These are the only 2 of that class that we use. And again, we have to be judicious because, you know, the person's blood pressure is already low, and I give them this medicine, they can get even lower. So it is all about gently titrating them to where they were. The last or the newest kid on the block are called SGLT2 inhibitors, okay? SGLT2 is a small protein in your kidney that resorbs glucose. 80 to 90% of glucose that filters out of the kidney is resorbed back by this protein called SGLT2. Now, if you inhibit that, If you inhibit that protein, then you'll just urinate out all of the glucose. All right. Now, this is the medicine called Jardiance or Farxiga or Invokana. Those are the three. This medicine is a diabetes medicine. So I said, why are we giving a heart failure patient a diabetes medicine? Because by doing so, by getting rid of the glucose, it reduces blood pressure, it improves cardiac performance, and there's a plethora of data that shows this improves cardiac morbidity and mortality. It's very, very good for your heart. So all of the data now has shown it's become a class 1, green box, class 1 to give this to all patients with heart failure, okay? All patients with heart failure. Then, if needed, we can add further diuretics, if needed, further diuretics, such as loop diuretics, such as furosemide or Bumex or other diuretics if we need to. Again, being judicious on our blood pressure and watching. And then our fifth green box, okay, which is very important, is defibrillator therapy. Patients who have an ejection fraction less than 35%, who are on maximal medical therapy, okay, and still staying at 35% in persistent heart failure, they are at risk of sudden cardiac death. Boom. Starts with ventricular tachycardia, goes to ventricular fibrillation, and then you die. So those patients universally get a defibrillator. Okay, this is a standard defibrillator. That's standard of care. That's level of evidence A, class 1 indication. Okay. Now, if your disease progresses and you continue to have persistent symptoms, there are other agents that we can use. If patients can't tolerate the ACE/ARB/ARNI drugs or are African-American patients, they do better with this combination of hydralazine and isosorbide. If patients have dysynchronous hearts, such as wide pacing complexes, we put a third wire in. It's called cardiac resynchronization therapy. That's another thing we can do. Then we move into the level of evidence or class 2. There's class 2A and class 2B. Some patients, in spite of everything we're giving them, still go fast. Their heart rates still go fast. In spite of maximum beta blockade, they still go fast. And that's because they're having beta blockers only work in the center of the heart. There's a switch box in the center of the heart. But some patients they're going fast from their sinus node. So we have this other drug that we can use called Corlinor that slows that down if we need to. It's a class 2A indication. Patients who are anemic, heart failure patients who are anemic, who have low ferritin levels, do very well by getting intravenous iron. Intravenous iron. So we do that a lot in our heart failure patients who have anemia. Okay. Again, class 2 evidence 2A. One of the newest drugs that just came out was verisugat. This is a drug that promotes cyclic GMP. Cyclic GMP is a very good vascular relaxing drug. It relaxes the vessel, so it improves cardiac flow. We use this a lot. That's a class 2B. And then the last drug that's in our armamentarium is a very old drug called digoxin. Digoxin works very good at improving the contractility of the heart. Gives a little extra squeeze. So we use it in refractory heart failure patients if we need to, but it is class 2B, and you have to be careful because you have to monitor the toxicity levels of digoxin. All right. So again, this is the treatment and management of HFrEF. Okay. And again, we want to go to titrate those drugs up until the patient can tolerate maximally. At this point, I'll take a break and stop if there's any questions, and if not, then we'll move on to the next topic. Any questions? Wow, you all got it. All right. Oh.
We would hear an awful lot of definition of heart failure around the hospital, and they'll talk about it as heart failure or congestive heart failure. They don't seem to ever use the term.
I know. That's because, unfortunately, and I'm just going to tell you guys, and I'll probably get in trouble. This is our 4th annual Cardiovascular Symposium. How many residents in the room? Not one. Nice. This is the 4th time we've done this. Maybe they're by Zoom, I don't know. If I was at Mayo and this, they'd kill us. But there you go. We try to educate. They got to attend. It's a sad fact. Okay, so let's move on to HFpEF. This is heart failure with a preserved ejection fraction. Heart failure with a preserved ejection fraction. These are people who have an ejection fraction greater than 50%. I'm really glad you asked that question, so I was able to give them the zing, you know. They don't listen to me. I'm probably going to get written up though, but that's okay. Move on. So heart failure with preserved ejection fraction, also called backward heart failure, the old term, also called diastolic heart failure, the old term. These are people who have a normal pump but have symptoms, okay? And we go back to diastolic performance. When we're talking about HFpEF, we're talking about systolic performance. This we're talking about diastolic performance. This is the other part of the cardiac cycle. Diastolic performance is the ability for the left ventricle to fill. This is cardiac input, not cardiac output, cardiac input, filling the heart. And during diastole, the left ventricle, the left atrium, the pulmonary veins all go back to the lung and form a common circuit. They form a common circuit, okay? I'll go through that in a second. Heart failure prevalence, HFpEF prevalence is increasing. In fact, it's slated to take over HFrEF soon, okay? It is increasing significantly. The rates are taking over. That's why I spend a little bit more time about this topic. And why is it taking over? Why are we seeing it more and more? Especially we're seeing it much more in women, is because our diagnostic abilities are getting better. Further, there's increasing rates of obesity, increasing rates of diabetes. These are all causing increase in the prevalence of HFpEF. Okay, so when people, before used to talk about the heart, we only focused on the ejection fraction. And that's what everybody cared about, was the ejection fraction, nothing else. All hail the mighty EF, nothing else. But there's more to it. Now we know there's two cycles. There's systole and diastole. Systole is when the heart pumps. Diastole is when the heart opens. So anything wrong with the systolic performance gives you HFrEF. Anything wrong with diastolic performance gives you HFpEF. And they are symbiotic. Okay, you can't have one without the other. Okay, so anything wrong with the ability of the heart to fill, okay, will cause this problem in diastolic performance. Remember, it's a common circuit. So the left ventricle, when the mitral valve is open, this is diastole, when the mitral valve is open, the left ventricle pressure is contiguous with the left atrial pressure. That same pressure goes back through the pulmonary veins. That same pressure goes back into the pulmonary capillaries, and that causes shortness of breath. That's the pathophysiology of shortness of breath. That's why you feel short of breath. Increasing pressure here in the called LV-EDP, increase this pressure. Back pressure goes to the LA. That back pressure goes to pulmonary veins. That back pressure goes to your pulmonary capillaries. Can't breathe. That's the pathophysiology of shortness of breath, effort intolerance, pulmonary congestion, and HFpEF. Okay? So now let's get a little technical. Let's see if I can do this. Get that to play. Get that to play. These are two echocardiograms. These are apical four-chamber views. This is, to orient you, the left ventricle, the right ventricle, the left atrium, the right atrium. Same thing on this side. Left ventricle, left atrium, right atrium. And if you look at this ventricle, it's normal. It's pumping normally. The ejection fraction is 60%. If you look at this ventricle, it's big, it's huge, it's hardly moving. The EF is 20%. This is a person with a bad heart attack in the past, okay? So, and I'm also showing you these inflow patterns. These are Doppler inflow patterns. I'll just tell you, this is one of severe diastolic abnormality. This one is impaired diastolic abnormality, not so bad. And so if I show you these two things, and just by a show of hands, ask you which patient is more short of breath, patient A or patient B? So let's just by show of hands, who do you think of A is, which one is more short of breath? A? Okay, B. More of you thought B. Well, actually, you're wrong. A. This patient is more short. This is the HFrEF patient, really bad ejection fraction, but relatively compensated with his diastolic function. This patient is more short of breath because he's got very bad diastolic function. Let's take it one step more. Which patient has higher pulmonary pressures, making them more short of breath? A or B? It would be A. Okay. Then the most important question, which patient has the worst prognosis? Which patient has the worst prognosis? A or B? A HFpEF patient versus HFrEF patient? It's actually A, the HFpEF patient. He has the worst mortality than somebody who has an EF of 20%. Okay, he or she, because that means that diastolic heart failure and diastolic dysfunction are not benign, are not. This is very old data published in New England Journal in 2006. The curves are the same survival curves for someone who has preserved ejection fraction versus reduced ejection fraction. Their survival curves are the same. This was old data. So we knew this very long time ago. This is not new, okay? Not new. And in fact, when you take a person who has had a heart attack and then look at their degree of diastolic function, that also gives a very significant mortality prediction. Somebody who has had a heart attack and has relatively normal diastolic function, they do well over 2 years. However, if you give this person any type of relaxation abnormality or diastolic dysfunction, pseudonormal or severe, we don't call it these numbers, but like grade 2 or grade 3, if it's a grade 3 person, in a month, they have less than 40% mortality, survival. Okay, that's pretty significant. Now, that's with a heart attack patient. Now, if you just take people off the street, okay, just random people off the street. Now, this is data from my old stomping grounds from Mayo Clinic. This was Maggie Fredfield and her group. What they did is they just took people off the street and did echoes on them year for year. I don't know how they bribed them. They did somehow. But they took, these are just young people, okay, off the street and did regular echoes on them over 5 years. If you had no or normal diastolic function, you did fine over 5 years. Your mortality was no different from the normal. But you had any degree of diastolic dysfunction, look at the mortality. It got worse in 5 years. Just random people off the street having diastolic dysfunction, okay? So why is that again? Look at this, these are pathology specimens. This is a normal heart, normal thickness, normal cardiac chamber sizes. That's what a normal heart should look like. Obviously, this person didn't die of a heart problem. This is systolic heart failure. This is like analogous at echo, big dilated ventricle, thin. Here's a scar here from a prior heart attack, hardly moving. So thin walls. That's a systolic heart failure heart. Look at the difference in a diastolic heart. Look how thick that muscle is and how small that cardiac chamber is, okay? So you can see the difference between the two pathologies, okay? Now, let's play this. Diastolic function is not passive. The heart just doesn't pump and then open. To pump takes energy, the muscle has to work. To open also takes energy, and the muscle has to open. You have to physically move the muscle, okay? Your heart does that, and that's an energy-dependent process. And you can think about it creating suction, and blood comes in from the upper chamber to the bottom. When it opens, creates suction, okay? And the blood comes in. And that's normal as we're young. It comes in very nicely. It's a very healthy pull, a healthy suction. Blood comes in, okay? Because the walls are very pliant. As we age, the walls become thicker. It's now, normally you could open like this. No, it takes a while to open. It's stiff. It takes a while to open. As a result, you have increased pressure inside your heart. So as opposed to a healthy pull, it's a laborious push. And this is what I always say. So this is what we see in a young person. So that's why I say young people suck. They suck very well, actually. Whereas older people don't suck so much. All right. I'm probably going to get written up for that too. So what are the causes of diastolic dysfunction? Okay. Hypertension. I can't say it enough. Hypertension is such an important cause of diastolic heart failure and diastolic dysfunction. So when we suspect this in anybody who has a normal ejection fraction and symptoms, the ejection fraction is normal, they can't climb the flight of stairs, they're short of breath, classic heart failure symptoms, with an elevated BNP, they're not just out of shape, okay? With an elevated BNP, that's the diagnosis of HFpEF. Now, we have other ways of checking. We have prediction scores. This is one of our latest scores that we use. A lot of us have this on our phone, and we can predict what's the probability of having it. The more overweight you are, increases the risk of having HFpEF, so BMI greater than 30. Hypertension, That's right there. So that's if you're taking 2 or more medicines for hypertension, that increases your risk. AFib, if you have atrial fibrillation, very strong, pushing you into the HFpEF category. If you have pulmonary hypertension or increased pressure inside your heart, that's another important one. Age greater than 60, very important. And then filling pressures, again, increased pressure on the inside of the heart. If we add these scores together, we get a HFpEF score, and that tells us it correlates to the probability of having HFpEF. Okay, so we use this as an adjuvant when we're trying to predict whether this person has this or not, and then give the appropriate therapy. Now, there's newer technology coming, and we hope to be getting it soon, using artificial intelligence. Artificial intelligence, we're using a lot of this in medicine these days. And the latest methodology is that the ultrasonographer will do your echo. That echo will go to the database. That database then gets sent up to the cloud. And these big, massive computers compare your echo, it's anonymized, your name and everything's off, compares your echoes to millions of other pictures within the fractions of a second, and then sends that information back to the database, and then it goes to the doctor to read. Pretty cool. So the doctor will have, in ISCV, the doctor will have his normal echo, and at the bottom will have an augmented report by this artificial intelligence thing saying, oh, by the way, this guy has an 85% probability of having HFpEF. So it's very helpful and very informative. So we're working on getting that here at Eisenhower. If we can get all the ducks in a row, that would be a very nice thing to have. So we're using artificial intelligence a lot more in medicine these days. Now, again, going back to the treatment of HFpEF, we want to follow guidelines-directed medical therapy based on the level of evidence. We like everything in green if we can have it. We only have one in green. We only have one class 1 indication, which is get the blood pressure down. That's the class 1 indication, get the blood pressure down. Okay. Now, there are other drugs which are level of evidence 2A and 2B. Jardiance, 2A, Jardiance, again, a diabetes drug for patients who don't have diabetes, who have HFpEF. I get this all the time. The patient will come in, they'll have HFpEF, we'll give them drugs. The pharmacy will call, hey, this person doesn't have diabetes. I says, I know, thank you. Fill the prescription, please. You know, it's not for diabetes, it's for this. Okay, because it brings down the blood pressure, and it has exceedingly high mortality benefit to patients who have HFpEF. Okay, and this is very well documented. In other 2A indication is if you can get rid of AFib or manage AFib, control the AFib rates, that also helps people subjectively, symptomatically with their symptoms. Okay, now 2B drugs, diuretics, specifically the mineralocorticoid receptor antagonists such as spironolactone or eplerenone have been shown to be very beneficial in these patients. But if we have to do others, we can. We can also use ARB drugs. We can also use ARNI drugs such as Entresto. That's also a 2B indication. So really any of the drugs that we have been able to use in HFrEF, except digoxin, have been shown to be very helpful in HFpEF. The one drug that we do not want to use are nitrates or PDE5 inhibitors such as Viagra or Cialis. These are the drugs that we use at high doses for patients who have pulmonary hypertension, okay? Not for sexual dysfunction, but when we're using it for pulmonary hypertension, we don't want to use it in this class of patient. It's actually a red box, level 3, do not use, bad, potentially harmful, okay? So these are how we treat HFpEF patients. And again, each class of drug, increase it to the maximum that the patient can tolerate. Same concept, maximize GDMT. All right. Well, again, bring the hypertension down. That's the key thing at the end of the day for these HFpEF patients. That's all I have. Any other questions?
Maximize the dose instead of this counterintuitive. You think you start with the minimum dose?
You do. No, you start with a minimum dose and you upwardly titrate to get to the maximum dose that the patient can tolerate, not the maximum dose that the drug comes in. You mean the drug may come as a 100 milligram strength. I'll never get there. I may just get to 12 or something like that. Okay. It's the maximal tolerated that the patient can tolerate. Okay. Maybe I missed it, but what's the cardiography technology? Is that just like big yes. So that's ultrasound of the heart. That's our workhorse that we use every day. Echo is a great tool that we use to look at the heart. It tells us the heart pumping function. It tells us the heart chamber sizes. It tells us the thickness of the heart, the walls of all the chambers. It tells us a lot of the pressures. We do a lot of hemodynamics from echo. So it's one of our standard tests that we do when we see patients. That you were looking forward to getting. No. We were looking forward to getting, there's this artificial intelligence add-on that we can get. We're looking forward to getting it if we can get it. Yes, ma'am. Jardians. No, see, that's a great question. Those are GLP-1 agonists, okay? They are very good drugs for heart failure. The Mayo Clinic published in April, I believe it was March of 2023, 2 papers showing that patients who have the use of Ozempic in both heart failure with preserved ejection fraction and heart failure with reduced ejection fraction, those patients did better on that drug. It was such a good paper that the FDA then put Ozempic and Mounjaro as indication, as heart failure as an indication. It was added by the FDA. Insurance companies don't care. They still won't pay for it. Just this year, they added sleep apnea that showed that use of these drugs help in sleep apnea. FDA put that on as an indication for using these drugs. Insurance companies don't care. So there's a lack between what the FDA says you can do and what the insurance companies will pay. But it is a good drug. It is a very good drug for HFpEF and even HFrEF. Okay? Because if you think about it, you're lowering your glucose, you're lowering your body weight, you're improving your cardiac performance. Makes sense? Sorry. None. Because we're only talking about the SGLT2 drugs, okay? So not talking about Ozempic. But those drugs we give to non-diabetics, okay? We don't monitor their sugar, okay? Now, if they come back and say, hey, I'm passing out and having symptoms, that's a different story. Then they are getting issues and we'll cut it back less. We're also not giving those drugs at the diabetes level. We're giving it at a much reduced level. Jardian's diabetic dose is 25 milligrams. We give it at 10. Okay. We don't give, it's not recommended to give these drugs to patients who are type 1 diabetics or type 2 diabetics on insulin. If you're on insulin and you're a type 2 diabetic and you have HFpEF, I have a lot of reservations about giving you Jardians because you're already on insulin, because then your propensity to get hypoglycemia is very high. Any other question? Yes, ma'am. Sure. They don't have a mic, huh? I don't know where our monitor people are. Is there a mic? Oh. Where? Oh, there. Oh, there we go. So our monitor was asleep. Okay. We give it to that guy up there. It's not, I don't think it has to do with it's not with the oxygen delivery, because you're still pumping the blood to the heart, to the body. Okay, so, and they haven't really shown that just because you have HFpEF, you're having, like, your oxygen levels are low. Okay, they're not going to go. You're still pumping it to the lungs, you're still oxygenating. It's the mortality is worse because of your treatments are limited. You just don't have a whole lot of treatments that'll bring down blood pressure. Okay. Yes, ma'am. We don't want to see the top number less than 135. We want to see the bottom number less than 85. That would be ideal if we can do that. Hard to do. In the elderly population, we have to accept a little higher blood pressure sometimes. We often are overzealous. We want to get everybody's blood pressure down, and they come back with syncope. They come back passed out. They can't handle it. You know, so we have to be, just because the guidelines say you have to be less than 135. If you're 85 plus and you've had high blood pressure for so many years, it's very hard to bring your blood pressure down. You won't tolerate it. Okay, you may have adverse effects. So we have to be a little judicious. There's practical and there's pragmatic. Nursing students, notice, no residents, nursing students.
Yeah.
Keep that. That's another thing I'll get written up for. Go ahead. I'm gonna get yelled at when I leave. Yes, the muscle is thicker. That's exactly what we said. As you age, everybody gets diastolic dysfunction as you age, okay? But the degree of how you can compensate will determine whether or not you'll have symptoms or not. But it's just a natural part of aging for your muscle to get thicker and get a little bit weaker in the heart. Any other questions for me? Yes, ma'am. I'm joking. That's okay. It's okay. All right, well, that'll end then. And who is our moderator to introduce our next speaker? We'll find out. But what